This is not mentioned in the literature, but I am coming across more and more people who experience problems with speech or voice. Query, a definite subgroup. Would there be an opportunity for this aspect of ME to be discussed? Yes, there is. And I think, John, you mentioned something about the voice, didn't you, in your presentation? And I wonder if you've got any comments about that.
We certainly see patients with intermittent hoarseness, and sometimes can be fairly prolonged. And we don't know for sure, but we have had several of these patients examined by the ear, nose, and throat doctor. The very crude way for the physicians to look at it is to see if there's inflamed tissue. Usually there is some hypopharyngeal or tissues right above the vocal cord are somewhat inflamed. The vocal cord itself is a little hard to see, and sometimes it's a little bit edematous. That's the best they can do. And we have never really looked at it when they're sick and when the voice is well. And no one's taken a biopsy of the vocal cord.
Thank you. Anyone else got to? Yes, Martin, please.
Well, it's quite interesting. The voice, the larynx is very close, of course, to the pharynx, and the pharynx is a place where the herpes viruses, Epstein Barr virus and cytomegalovirus and herpes virus exist and actually can be in latency. It is remarkable that there is a specific lesion of the pharynx in patients with Epstein-Barr virus. It's a hard exudate that they feel, and you see if you look into the pharynx and see it, which is very, very different than the exudate of group A streptococcus. On the other hand, the patients that I see with the chronic fatigue syndrome are sick and weak. And your voice isn't very strong when you're sick and weak. And it may be a generalized phenomenon of the chronic fatigue syndrome.
Thank you. Irving, please.
I've had several patients referred from speech therapists who've sent referral letters saying that this patient has ME. Why shouldn't they have speech difficulties? Because of muscle weakness, of vacation. And the more tired the patient is, the more slurred their speech is.
Thank you very much. So, something that's regarded as unusual and not been noticed very much has been noticed, and the smart guys have seen it, and it seems to be part, in some way or another, of the expression of the illness. There's now another question. This is a $64,000 question. During May, there has been a lot of press regarding promising research. Could someone please give a timescale as to when something is likely to be available for people with ME in order to help them? Well, sorry, go on.
I think there are things available.
I agree.
And I think we'll use them in the appropriate situation. There are numerous anti-inflammatories. That's why Carl Ware came along, and Jonathan showed in his slide this morning. We have things that we're using to treat various lymphoproliferative diseases. I didn't show the case history of the longest living patient with mantle cell lymphoma got chronic fatigue syndrome 25 years ago. Never was cognitively clearer than when on Rituxan, which is a monoclonal antibody targeting the CD20 B cell, suggesting that B cell response I showed that was awry was part of the problem in the pathogenesis. Also, the drug called Velcade is a proteasome inhibitor that targets NF-kappa B. There's lenalidomide, which targets multiple cytokines, inflammatory cytokines, including TNF. So if we can subgroup our patients according to the right population, I think there are treatments there. Jean showed quite nicely with immunotherapy what low dose. What we need to do is just define exactly so that we can stratify the patients that will respond, just like in cancer therapy, so that we don't subject patients to unnecessarily and toxic treatments and give them ones that will actually be efficacious.
Martin?
Well, I think the whole point of my talk was that we do currently have specific antivirals which, if administered, appropriately and safely can save many, many, many lives here. I think that this was the essence of what I was trying to show over the 20 years of our experience. So I think it's here. Now we need all of the things that all of us are doing, and we need a lot of development, but I think the data that I showed are very hard to call preliminary.
Thank you. That was my impression, certainly. But it's the appropriateness. If you don't get the right subgroup and give them the wrong therapy, it's not going to work. And people are going to say it's not effective. So the whole thing is identification of the right subgroup. Len, please.
Just to add one other thing to the excellent ideas that have just been expressed. One of the things that we really need is the natural history of this illness. We need to have large groups of people that we can follow over time and see the natural history and what types of things people are using to try to change their situation. And that's just a high need for us internationally to develop those samples so that we can learn some of the answers.
Thank you. That leads on to the next question, which someone's asked. If a child gets ME and fits the pediatric definition, as they grow up, will their symptoms change somehow to fit an adult pattern? So the development through the child expression of ME into the adult pattern, is that something that you see and recognise as being significantly different?
The only thing different about treating children is that they respond very more dramatically and rapidly.
Right.
And it's extraordinarily gratifying to treat a child and see them unable to go to school, unable to exercise, in bed, and just within a few months, they're completely transformed. So that's the easiest job if we can recognize it. Now, I could tell many stories that are not scientific about the political battles that we've had in order to have children from poorer families who could not afford the tremendous costs of all of this to do it. But we've had patients who've gone to their Congress people, to their representatives who have made enough political noise so that somehow their medicines occurred. It's gratifying to treat children.
Sorry.
Go ahead. In children younger than 16, we find that gamma globulin works a lot better than when we use it in adults. And we have a number of patients going to remission after 2-3 consecutive doses given on a daily basis. In adults, that works less than 20-30% of the time. In pediatric patients, probably more than 60% of the time. But the patient cannot exercise immediately afterwards. They basically have to pace themselves for 6 to 12 months. I mean, they can actually go from a bedridden state to back to school, but they just can't exercise until gradually the inflammatory response, I think, subside. And it's interesting that a number of these patients will come back in the next few years with part of their symptoms, like either brain fog, abdominal pain, or muscle pains, but not the whole feature of the chronic fatigue syndrome.
Len, you were wanting to add.
One of the positive things about the prognosis is, as Martin has suggested, that for youth with this illness, it does seem like their trajectory is different than with adults, and maybe that has something to do with getting there early, and maybe we can learn something that not 6 months, not even 3 months, but much earlier. When people are sick, we should intervene early, and maybe children have that kind of malleability because we're just intervening. On the other hand, I think we need to notice something else about youth, and that is that while adults certainly kind of struggle and have difficulties with work as well as health care with this illness, the particular issues with children and adolescents could be far worse. Because if you're in a system that, as we've all heard reports, of a child taken away from their family, or kind of legal authorities working with those youth, the types of potential damage that can be done is incalculable.
Thank you for that. Yes,
Yes, certainly. Children, once they get out of puberty and their neuroendocrine system stabilised, their neuroimmune system stabilised, they fare much better as regards to improvement from youth to adulthood. But on the other hand, they still must maintain a disciplined approach to life.
Dr. Park, do you want to say something about immunoglobulins?
Yes, I have some comment I want to make. A lot of people using the immunoglobulin nowadays, and we are the one using for the last 10 years, 1 gram IgG for all the patients. Now, the children cases, if one family member has a CFS, their children all have CFS. It's crazy, but it looks like a contagious disease. In the case, the children comes with some CFS symptoms, and all we treat IgGs, and they respond like within 2 to 3 months. Their cognitive function improves, their school grade improves. That's fantastic.
Thank you. That's very helpful. There is an issue, I think, around how the IgGs, the immunoglobulins are administered. There's some reticence in the UK not to give it intravenously, but I noticed on your poster you were giving it IV, Dr. Park.
Yes.
Yeah.
We give IV 1 gram in 500 cc's of the normal saline once a week.
Right.
For 3 to 6 months.
Does it happen in the States? Do you do it IV in the States as well?
Yes,
yeah,
I
you do,
think
right.
Dr. Dan Peterson is the same thing.
Dan Peterson does
Yeah.
as well.
Yeah,
Yeah,
right.
same
Well,
thing.
that's interesting because getting IG now is difficult because the sources are very difficult to get hold of, and there's been some limitation on that. And I think you might have had some problem, haven't you, Irving, in getting immunoglobulins for your patients?
No, I don't have any problem getting immunoglobulin, and I give it IM because the vortex of effects is just as effective, and there's probably just that bit of reduction in risk of serious viral contaminants in IV.
Right. Yeah, thank you. There's a question here from someone in the audience. Why does activity, I think they mean physical activity, reactivate the virus? Go on, Martin.
I can't speak as eloquently as our colleague Judy can here, but I can speak in terms of the cardiac findings that we find in our patients. And even for the non-pathologists, this is a weakened tissue which stretches and doesn't act very well. And you don't exercise a weakened heart. You wait till it's well, and then you exercise it so it will become stronger. And pacing the patient during the recovery period is remarkably important. And the way I tell my patients is, if it's easy, do it. And if it's ever not easy, don't do it. And don't do anything that leaves you tired, because the next day you're sure to be worse. The way you get well is to increase what you do when it's easy and have the next day like it. And that's critical to the healing period here. And I guess I learned that from our physician here, who I'm sure would agree exactly.
So you see,
Let me explain one of the things that what Dr. Lohner says about. It's exactly like a MI patient who has myocardial reserve is low. That this patient, if they do exercising in the upper extremities, they're getting worse very fast within a few hours, not just in days, a couple of days. Cardiac reserve is really low in this patient.
right.
Well, may I just comment on that also? We do see quite a few patients that had echocardiograms that show totally normal heart functions. And yet when they just go and walk a block, they will be extremely fatigued, whereas they could run 10 miles a day before they got sick. I think the explanation is not just the cardiac issue. I think it's the muscles. Because a number of physicians, researchers go Behan, Galbraith, Yosef, and Lang, et cetera. They have demonstrated the viral RNA in the muscles. It's just hard to find RNA in the muscle. It's kind of like finding a needle in a haystack. We have so many muscle fibers. Each muscle fiber is so large. So the fact we don't find it in everybody doesn't surprise me at all. But I think the RNA is in the muscles. If you exercise, you increase the metabolism of the muscle cell. There's viral replication. It's going to interfere with the cell function. I think eventually that's what happens.
Irving, yeah.
The other thing is when you do serial VP1s and they become negative, and then someone goes out and does a great deal of exercise, and you do the VP1s again, they're positive. So exercise in some way must increase the cell's ability to produce virus or free virus into the bloodstream.
It's immunosuppressive.
Jean, you want to say something?
Well, I was only going to say that we've shown in our patients that practically all of them had degrees of anoxia in the capillaries. The viruses will replicate in that sort of medium. So exercising adds to the anoxia because it's using resources. So it's inevitable, really. So I think
It's free radicals by the mitochondria. That's the definition. Of
That's right, yes.
yes.
Go on, Mark. Thank you, Jean. Martin.
You know, we all remember that the earliest Holmes and the more recent Fukuda definitions of the chronic fatigue syndrome indicated no cardiac involvement. And if one looks at the stationary resting electrocardiogram in patients with the chronic fatigue syndrome, they're 95% normal. What happens is the abnormalities that are common to anyone who looks at abnormal electrocardiograms is that they occur with exercise.
Right.
We did myocardial dynamics in 100 patients with the chronic fatigue syndrome, and we found abnormal dynamics, the heart going in or out or asynchronous in 10% at rest and 21% with exercise.
Thank you very much. It does raise the question about some of the things that were suggested. I'm sorry Julie's not here because she was suggesting this tilt table training. But it did seem to me that if you were going to start trying to train a muscle before it was ready for it, you might actually run into serious problems. So your energy index, Martin, would seem to be very helpful in determining when to start this sort of exercise.
It's critical,
Yes.
and it's reproducible.
Right.
And it can be done by anyone and everyone. It doesn't take a great deal of time.
But only when people are ready for it.
I'm talking about finding the energy index, but exercise can't be until you're past 7.
Right, yeah.
And 7 is critical. You don't need a nap. You don't lie down.
That's right.
These things are reproducible over and over and over again.
Yeah. Len?
Just to mention some of the really interesting work of Stacy Stevens and the group in California. They do cardiovascular testing. And what they found is interesting, that sometimes when you do these tests, patients rest for a considerable amount of time before they sort of do the test, and then kind of collapse after, but they're not available to sort of show that test and that exhaustion that might occur. So I think we need to recognize that sometimes one-day tests, at least her group, do not always find abnormalities. What they have done is brought the person back the second day, and during that second day of testing, every one of those patients shows incredible problems. So just kind of remember that sometimes, even though patients might go into some type of testing, and actually that particular day they might actually look okay, that's because they might have rested for several weeks before that. And then they basically do okay, but then they leave and they don't realize that their performance is being evaluated as sometimes within normal level. That's because no one has actually looked at what happens the next day or the next week.
Thank you. Jean, were you wanted to come back?
Oh, only just to say that the structural things in the heart may be okay as far as a cardiologist is concerned. I mean, they haven't done the biopsies that have been shown to us here, but what we like to use as an analogy is what's going wrong with the heart is it's like a plastic bottle full of lemonade or something, and you're pressing hard, and if it's got the lid on, nothing happens, and there's a huge amount of effort until the lid pops off. When that function is not possible for people with chronic fatigue, because they haven't got the strength for the contractility of the heart muscle. That's what fails, and that's not shown on normal tests.
Right. Well, I don't know if the person who asked the question is here, but that's a complex answer, but it's a complex disease that we've got. But I think it's been very comprehensively answered now. There's a question here about the use of interferons. Is it possible that someone wants to hear a bit more about whether there's a conflict of opinion about what people's experience is with the use of these interferons? Now, Jonathan, you were starting a study, weren't you, with interferons? Have you got any way into that yet, or are you still planning it?
Well, we applied for funding to do that study, but didn't get it.
All right. So
and the reason was that the research committee were concerned that interferon beta can actually mimic some of the symptoms of chronic fatigue syndrome.
Right. Yes.
Which is true, but it doesn't necessarily mean it's not a good idea to use it.
Again, suggesting you need to stratify patients. There are some people who it's not a good idea.
You're right. So some people... Sorry, Julie.
The drug Ampligen
yes.
is a toll receptor 3 stimulating oligonucleotide, and it basically cranks up interferons and allows NK cell function to come back. But Dan Peterson's experience, if he uses it in somebody with high levels of interferon, they become very, very sick. So that's the criteria. Yeah. Bad RNA cell activity, no interferon, use Ampligen. High interferon, don't. Yes, right.
So, I mean, this is just the complexity of the illness, again, sort of defeating us. If you can get it right, it works. If you can't get it right, you can make things a lot worse. Is that generally the experience of the others who've used it? Have you used interferon, John, at all?
You mean beta interferon?
Well, either, any of them, but people have mentioned beta, but alpha's being used as well, isn't it?
One of my patients actually was misdiagnosed as having multiple sclerosis, so the neurologist gave him 6 months of beta interferon. He took the first month, he almost died, so he didn't want to use it. He did not get better, but the second time, in about a year or so, he used it for 3 months. He actually recovered completely, although about 3 months after that. So beta interferon is more active against enterovirus in the tissue culture as compared to alpha interferon. That's why I use the alpha and gamma instead of beta.
Well, that's very helpful. Again, you have to have the expertise to make these clinical judgments about when to use these things, and that's if you don't stratify your patients, as Julie was saying, then you're going to get it wrong and screw up, and the patient's going to suffer. But that last one is a very interesting example. I'm afraid we've run out of time, folks. I hope you found the question and answer session helpful. I certainly have.